Good morning. A very warm welcome to this teaching capsule on the first successful pediatric live donor liver transplant carried out at the North Colombo Liver Transplant Service. Uh, Please excuse us for any glitches because we are on Zoom, but we'll try to do our best. We have a panel of consultants and trainees who took a very active part in this transplant and who are responsible for mainly responsible for its successful outcome. Organ transplantation is the treatment of choice for end-stage disease of various organs, the kidneys, the liver. And the pioneer was Dr. Thomas Tazer, a surgeon who started in 1963, but after lots of failures, he's finally succeeded in 1967. Lots of lessons to be learned there. Organ transplantation is considered as one of the greatest advances in medicine of the 20th century, but it's a very complex procedure involving multiple stakeholders. It's very labor intensive. It's very costly in terms of capital and recurrent expenditure. Needs a sophisticated infrastructure and a very robust legal and ethical framework for these programs to work successfully. In some countries, transplant has failed because it was not culturally acceptable, but not so in Sri Lanka. In the case of Sri Lanka, the milestones in liver transplantation go back 20 years when postgraduate training in transplant hepatology and surgery commenced in 2001 and 2003 respectively. Cadaveric liver transplant, the first successful cadaveric liver transplant was carried out by the University of Colombo Surgical Unit at the National Hospital Sri Lanka in 2010. We started cadaveric transplants in 2011. The live donor transplant was followed by a transplant for acute liver failure in 2017. And the pediatric transplant that we are focusing on today was in 2020. The special interest training in transplant anesthesia and critical care was started by the Board of Study in Anesthesia in 2017. I think it was a major step in the development of this field. We are a nomadic tribe. We go all over the place. We move theaters. We move to different hospitals to carry out our transplants. But we always try to give up our best. It has taken 20 years of planning and developing human resources, training transplant surgeons and hepatologists. But surprisingly, training specialist transplant anesthetists started only in 2017.
And firstly, I would like to thank the College of Anesthesiologists and Intensivists of Sri Lanka for joining me this session. I have to mention firstly, I'm a general pediatrician, not a pediatric hepatologist, but I have to play the pediatric hepatologist perspective for the time being. So I would like to give you a little background about first pediatric living donor liver transplantation in Sri Lanka, as well as the current situation in regards to pediatric hepatology. Yeah, firstly, I think it's good to talk about the magnitude of the problem in Sri Lanka. What is the disease burden? Firstly, I would say about chronic liver cell disease, and then I will move to acute liver cell disease or acute liver failure. If you ask me the incidence and prevalence and the statistics, I'm afraid I cannot share that information for the time being. The reason is the figures are not estimated yet, simply due to lack of national data, which is something which we need to work on. However, what we see is the tip of the iceberg, because there are a lot of children who are dying and who are having a lot of morbidities across the country due to chronic liver cell disease, and they simply die in the absence of liver transplantation. And for many decades, it had been the norm. They are destined to die, though it should not be the reality. So I'll give you some figures for you to get some understanding about the current disease burden. The children who were able to afford for liver transplantation from a single center in India, from our country in 2018 were 11 and 2019 were 10 children. So as you know, since we did the first liver transplantation for a child in Sri Lanka in last July, there were no successful pediatric liver transplants carried out in Sri Lanka. Hence, the children who are needing that, unfortunately, had to go to overseas, mainly to India, to a single transplant center, which is quite popular among Sri Lankans. So these data were brought from them. There are 11 children went in 2018 and got their transplants done, and 10 children got their transplants done in 2019. The cost is around 80 lakhs to 100 lakhs, which you can imagine how many of them would be able to afford for. So that's why I say this is truly the tip of the iceberg, because there are many children, maybe 10-fold, 20-fold, who are dying, being unable to afford for this cost. In UK, nearly 75 pediatric transplants are happening per year in 3 centers. And let me share some raw data from the unit, from our unit, since March last year, for about last 10 months. Since we established our services as a ped liver unit, we had 50 new inward referrals of chronic liver cell disease that was over past 10 months. The estimate is for about 60 per year. I hope you could see this is just the start of the unit, so the referrals would come more and more, the numbers would be more and more. And everybody doesn't require transplant at the initial presentation. Possibly 60% would require. I think I would be able to share the correct data maybe in 1 to 2 years' time. Just to talk about the spectrum of the chronic liver cell disease, I think I should mention the disease spectrum firstly. The commonest indication for liver transplantation in children is biliary atresia. I think if I see 100 children, 85 would be biliary atresia. That is the commonest indication for liver transplantation in children. By the side, there are genetic disorders like Alagille syndrome or progressive familial intrahepatic cholestasis and so on. And metabolic diseases as well, storage disorders and viral hepatitis, though they are relatively uncommon compared to adults. Apart from that, autoimmune liver disease, oncological conditions, drug-induced liver disease, and hemosiderosis, which may be primary or secondary, especially in transfusion-dependent anemias like thalassemics, are common among the spectrum. This is the phenotypic spectrum actually. You can see there are little infants and older children, and they present at different stages. Some of them present quite early, however, most of them present very late, where we are very unfortunate we can't really offer anything for them at our setup at the moment. I think mostly we talk about the chronic liver disease and the decompensated liver disease when we talk about liver transplant. Acute liver failure as an indication for liver transplantation in children should not be forgotten. They also get acute liver failure due to infectious causes, maybe autoimmune liver disease, Wilson disease, or unique diseases like HLH, hemophagocytic lymphohistiocytosis, which are quite common among children, and maybe drug-induced liver disease. So our target should be to offer our services for both these categories, not only for chronic liver disease. I think that is what I wanted to tell about the magnitude of the problem in Sri Lanka in brief. And I would like Prof. Rohan Sirivardhana to take over from this point regarding that matter.
Thank you, Maranti. Rather than moving into that, I think just a few things to mention. We in Sri Lanka, it's around 2011 that we had the first cadaveric transplantation, and it took us almost 9 years to do the first pediatric transplants if you look at the whole country. And even still, for a given year, adult and pediatric, just leave behind pediatrics, adult transplants, really only about maybe 9 to 10 transplants are happening a year. But the number of patients who are waiting for transplants, who are waiting in the list with cirrhosis is quite disproportionately higher than the number of cases that we are doing. So that brings us to another important area. Why the number of transplants are not happening at the amount that is required at the country. One main problem is that we had was lack of trained people. But now, last 2-3 years, a lot of trainees who have gone abroad, and they have come back to Sri Lanka with specialized training. So I think now it's the time that now initially first few years the problem that we had was the lack of trained people. There were no people who do transplant. There were one or two people who were just struggling to get things going. But now things have changed. Now there are people who are back. But now the next issue that we should be looking at is the donors. So talking about donors for transplants, we look at two types of donors: cadaveric donors and living donors. I think we'll come to that in detail later. But I think Madam, talk a bit about donors.
This is Dr. Nilmini Vijayasuriya. She's a senior consultant anesthetist at the North Colombo Teaching Hospital. She's going to take us through the problem of the scarcity, or donor organ scarcity, and the steps that are being taken to rectify that. Over to you, Nilmini.
Thank you, and I want to talk to you all about the scarcity of organs for the donor transplants in the country, and how to effectively and allocate these organs to the people who need it. So if you look at the supply and the demand of the organ transplants, the donors living and cadaveric, it's never going to match the demand that we are facing every day. Especially now in our country also, there's an increased burden of non-communicable diseases, increasing life expectancy. We are seeing more aged people, and also success of the transplant programs in many centers have made people to stay back home and get the services by the local teams rather than going to other countries, spending a lot of money. So the demand is ever increasing and the supply of donors is limited. So the problems that which are identified are the absence of a national registry about the donors, altruistic, as well as the people who would like to consent for organ donation upon brain death. And there is a very poor coordination of the whole process, which leads to wastage of potentially transplantable organs. And if you look at the patients who are admitted to ED and intensive care units, there's no uniformity of diagnosis of brain death, donor maintenance, retrieval of organs, and the allocation, and the whole process is not coordinated. And the services are also mal-distributed, and there's a lack of mechanism for central coordination between the institutions to facilitate and regulate transplantation. And even the awareness among healthcare professionals and the community about that organ transplantation is the preferred method or mode of treatment at the moment for end organ failure is also lacking. And to complicate all this, there's organ trafficking, which is related to financial relations in this whole business. So considering all these things, Ministry of Health has got together with the specialists who are struggling very hard to get organized and establish a successful transplant service in the country. They are looking at the legal framework, and they are in the process of establishing a national policy on organ, tissue and cell transplantation in Sri Lanka. So the current legal framework that we are guided by is the Transplantation of Human Tissues Act number 48, which is a quite old one, 1987, and the circulars that are issued from time to time by the Ministry of Health on organ transplantation. And this act is now outdated and needs to be revised, and that is the reason why they wanted to establish this national policy and to revise the current Tissue Act. So development and implementation of a national organ transplant information system is also quite important to coordinate the transplantation processes, thereby reducing the wastage of organs and potentially save another life. So there have been a lot of workshops, including throughout the country with the ministry and the specialists who are engaged in this transplant programs, and they have developed this strategy of having a information system which will help to establish accurate and timely country level statistics, which is we are lacking now, and to have a national protocol and a countrywide waiting list for organ recipients, and to collect data on the post-transplant outcomes of the recipients as well as organ donors. So the objectives of this database is to establish a transparent system where can be streamlined and coordinate the activities related to transplants, and to have appropriate and timely information dissemination to all the transplant teams, and to create and maintain a centralized register of donors who have consented to organ donation upon brain death as well as live altruistic donors, and to maintain a potential recipient database, and to implement a nationally accepted eligibility criteria so that it's transparent and it is a nationally uniform allocation, and to improve the efficiency of the organ retrieval process, and to improve the transparency, as I mentioned earlier. So this is the database layer that is being organized by the Ministry of Health, including a national transplant coordinator with the Ministry of Health under the DGHS and Director Transplant. So as an anesthetist and consultant who had been looking after intensive care patients for a long time, I feel that it is now we have to think about how we should help to get donors, and it should be a rule in potential donors than ruling them out. So it's a huge task that comes on us as anesthetists, intensivists, emergency physicians who are lifesavers, to make sure that we identify the potential donors as early as possible and have this national program supported by us, because majority of specialists, if you talk to them, they have no uniform system of identifying brain death. I have heard that some consultants even wait for a neurologist to come to do the brainstem death testing, which is actually sad to hear, because this is the circular that has been issued by the DGHS, where confirmation of the brain death and to promote National Deceased Donor Organ Transplantation program, which was issued in February 2020, has been sent to all the hospitals, but I'm not sure whether all of people who are having the power to do this, whether they are updated on this. Because sending a circular just to the director will not help unless there is some awareness raised among the people who are directly involved in decision making. So now they have sent, I'm sorry about this slide, it's not very clear, but the ministry has sent a notification of potential deceased organ donors form to all hospitals. And we did not get this, and I had to call them and ask to resend it again. So that's why I'm saying that communication between the national program coordinators and the ground level working consultant is not adequate. So we need to find solution, and that is why we thought of putting this topic for the our college sessions as well, to raise awareness among the people who are directly involved and responsible for identifying the potential donors so that it doesn't go wasted.
We've heard the pathetic state of the potential recipients. We've seen the magnitude of the problem in Sri Lanka, and we've also seen the steps that are being taken by the Ministry of Health and the health authorities to rectify this. Despite this, vast number of potential useful organs go waste due to the lack of knowledge and the lack of interest on the part of doctors and other staff dealing with these patients. I invite the consultant intensivists at the Colombo Teaching Hospital, Dr. Udya Rodrigo and Dr. Anushka Mudalige, to take us through the process of brainstem testing and also of optimizing potential donors to maximize the utility of these organs. Thank you.
So thank you again, Dr. Bhagya, for giving this nice introduction. I'm Dr. Anushka Mudalige, and I've been given this opportunity to talk on brain death testing and optimizing donors. And the distinguished speakers before me have laid down the basics and the background nicely. So I just have to talk about the clinical aspect of this on this topic. So first of all, we'll talk about the types of donation. I'm talking about donation after death here, or cadaveric. And first we'll talk about donation after circulatory death. So what is circulatory death now? When the criteria for brain death are not fulfilled, but the hope of recovery of a patient is very poor, then there is the point in the best interest of the patient to continue life-sustaining treatment. And it is at this point that we talk about withdrawal. So then the patient will go into cardiorespiratory death, and harvesting organs after this death is called donation after circulatory death. This has been the initial, the focus of organ donation, because initially there was no brain death being defined. So later on, brain death came up, the principle of brain death. And when we talk about brain death, by definition, it means there is irreversible damage to the brain that is demonstrable objectively, resulting in irreversible incapacity to breathe and irreversible incapacity to gain consciousness. So these patients are also a cohort for organ harvesting. So the difference between the two donations, between circulatory death and brain death, is we have more control, clinical control over brain death compared to circulatory death. As a result, the warm ischemia time would be less in brain death, thereby the organs are healthier compared to circulatory death. So now when you're talking about donation for circulatory death, they have to be done in very controlled situation. It's quite difficult to get the logistics worked in. So in Sri Lanka, we hardly ever do it. So instead we go for brain stem death, where it is much easier to get the preconditions settled. So to diagnose brain stem death, we have to exclude potentially reversible contributions to a state of apneic coma. So I have to emphasize there should not be any reversible cause for the coma state. So there should be no doubt that the patient has suffered irreversible brain damage of known etiology. So this should be as maybe a hemorrhage or a stroke due to trauma or spontaneous reasons, or any space occupying lesions that causes intracranial hypertension. Anyway, the brain is now, we should not have any doubt about the damage to the brain. After this prerequisite has been completed, then we have to formally demonstrate that the patient is in coma, the patient is in apnea, and the brain stem is not functioning anymore, as exhibited by absence of brain stem reflex activity. So these are some of the prerequisites that we should fulfill before we actually start to test the brain stem. The temperature should be normal. As you know, hypothermic patients could be in coma. Sodium, they have given a limit, because again, hyponatremia can lead to coma. Also glucose, they have given values, should be normal. Apart from that, these biochemical tests, respiratory and hemodynamic parameters should be within normal range. There should be no hypoxia or hypercapnia, and the perfusion to the brain should be normal, which is depicted by the mean arterial pressure. And there shouldn't be any endocrine disturbance at the onset of this coma, which could be hypothyroidism or Addison's disease. But afterwards, after brain death is ensured, the patient will naturally go into endocrine disorders, which are not included here. And the depressant drugs, because when the patients are in ICUs, we give them sedatives. We have to make sure that before we test it, that the sedatives have been eliminated from the body completely, either by giving time for them to be eliminated or by giving an antidote. Then after these prerequisites are met, we go to actual testing. So we test the brain stem. So brain stem has the cranial nerves. We do 6 sets of tests to test these cranial nerves. If all are negative, that is, there's no response, we go to the apnea test. The basis of the apnea test is we consider that the respiratory center is most sensitive to the rise of carbon dioxide. We liberate the patient from the ventilator, but we oxygenate the patient and let there be no ventilation for some time for the carbon dioxide to be built up. That carbon dioxide in a patient who has an intact brain is able to stimulate breathing. If there is no breathing, there's no doubt that the brain stem is dead. So we objectively demonstrate this. So who should perform the test? 2 doctors should perform it who have SLMC registration of more than 5 years and who have experience in doing the test. And one of them should be a consultant. When is the time of death? When the first set of tests have confirmed brainstem, we consider that is the time of death. When should organ donation be considered? The moment that first set of tests shows that the patient is brainstem dead, we should consider organ donation, because as Madam Nilmini earlier said, the more we wait, the more damage will be there to the organs, as well as the patient will become unstable. So what comprises potential organ donation management? So this should be a protocolized management. And also, so far we've been trying to save life. Now it shifts to preserving organs. And also the management includes talking to the family. Now in Western countries, all patients, in the UK for example, all patients who are brain dead are for organ donation. It's an opt-out system. Whereas in Sri Lanka, we have not come to that stage yet. So when we talk about brain death, we have to get the family into the picture as well. It's a very difficult topic to talk about, to understand and to explain. So it might cause some concerns during this transition where the families get involved as well. So once the family has all agreed, how do we go? Why do we have to manage these patients? Because there's a physiological change that occurs in the body the moment the patient's brain dies. There's increased intracranial pressure due to the ischemia and edema initially, causing a sympathetic storm. And this will cause left ventricular failure. And thereby, then later on, the brain starts coning because of the increased intracranial pressure. And with that, all the brain stem centers, the basal motor center, the respiratory, everything will shut down. As a result, all the organ systems in the body will get affected, as you can see in this slide. So if you leave these patients without active management, they will inevitably die within 48 to 72 hours. So in order to keep them alive, we have to actively manage them. As I said earlier, there should be a protocolized management to ensure a good outcome. So in ICU, we always go by organ management. So the airway, the patient should be intubated, and then ventilation, we go by these ranges, as you can see, the lung protective ventilation, and we try to keep all the parameters within normal range. Cardiovascularly, we try to maintain perfusion to all the organs that are supposed to be harvested. So the arterial pressures are maintained within normal range. If there are issues in maintaining blood pressure, we go for invasive monitoring. As you can see here, we have done pulse control analysis, even esophageal Doppler, any mode to make sure that the patient is cardiovascularly stable. Then the hypothalamus also starts failing in these patients. So all the hormones will die out. So we have to make sure that we start on these 4 hormones are the international guidelines that they have given to be started immediately. The temperature, again, because of the hypothalamus dysfunction, the temperature will the patient will become hypothermic. So we have to make sure the patient stays normothermic by ensuring active warming of these patients. So that would be the generalized management of a brainstem dead patient. Apart from that, specific management according to the patient's other clinical parameters should be done accordingly. Now, talking about diagnosis of brainstem death in children, the adult criteria can be applied for children older than 2 months of age. And one of the doctors should be a pediatrician. That's the only difference. Apart from that, less than 2 months, the problem is we cannot demonstrate it objectively, the brain damage. So we cannot meet the prerequisites. So it's difficult to elicit brain death in less than 2 years. And preterms, they don't have the cranial nerve reflexes. So again, brainstem death testing cannot be done in these patients. So with that, I have actually come to the end of my speech, and I would like to hand over back to Dr. Bhagia.
So we've seen the problem. We've seen the problem of getting donors. We know how difficult it is to get donors. We've seen that the cadaveric donor pool is not sufficient to meet the demand. And to bridge that gap, the concept of live donor transplant has been introduced. Professor Vansirivadana will talk to you about the risk to the donor and how we quantify the risk and how we select a suitable donor for a transplant. Over to you, Rohan.
I think Anushka talked about the complex procedure that we follow in cadaveric transplantation. But just briefly to tell what live donor liver transplant is, in cadaveric transplant, what you do is, in simple terms, in cadaveric transplants, what you do is you take a full liver, a full organ from a dead donor, either brain dead or cardiac dead, and then you transplant the full organ or part of the organ to the recipient. On the other hand, in living donor organ transplantation or living donor liver transplant, you take part of the organ from the donor and you transplant that to the patient. So that's a basic difference. But let's see now. Anushka described the process of cadaveric transplantation, and we heard that first of all you need to diagnose brain stem death, and then there are certain legal things that follows after that. Then the consenting from the relevant parties, and then a lot of logistics. We talked about the national database, and there should be a system to coordinate all these things. There should be a properly structured system. Without a properly structured system, cadaveric transplantation will not be successful. And that is what we see in our country, because inherently our country, we don't have a system. And if you look at the countries where cadaveric transplantation is successful, like Europe or America, they have well-established system. They have national transplantation coordinators, national transplant programs, where there is a system that takes for the whole process, and and the clinician's role is only to attend to clinical work. But here in our system, our setup, it is completely different. So that has led to many drawbacks in progression of transplantation in our country, especially the cadaveric transplantation. Let's look at the live donor transplant. On the live donor transplant, all that problems in logistics like coordination, donor maintenance, national center, things like that is completely eliminated. And if you have a donor, a right donor, and if you have the right patient, you can proceed the transplant. So it's a local matter that you have to take care of. So then that is what you see if you look at India. 95% or 90% of their transplants are live donor transplants. It's almost similar to Sri Lanka, where there is no system. In these kind of places, it's a live donor transplantation that is practically possible. But having said that, I'm not saying the cadaveric transplantation, live donor should be replaced by cadaveric transplantation. I'm sorry, I'm not saying that cadaveric transplantation should be replaced by live donor. What I'm saying is practically, in setups like our countries, where there is no established system, live donor organ transplantation has a significant role to play. But the problem with live donor is that you are dealing with the patient, you are not dealing with the patient, you are dealing with a completely healthy person. For instance, before taking organ, we make sure that this donor is completely healthy, and you are performing a 6-7 hour operation in a healthy person, which can result in death. If you look at the numbers, if you do 1,000 living donor liver transplant, at least 3 patients will someday will end up in death. So that's a significant outcome, even though it is 3 in 1,000. You are talking about a healthy person. So that is the problem in living donor liver transplantation, especially if you compare the livers and the kidneys. Living donor organ donation is actually, the surgery is not very complex. It's a complex surgery, but compared to a living donor liver transplantation, it's not very demanding operation. But liver transplantation, live donor liver transplantation, it's a very demanding. So you have to be very careful when you are offering a liver transplantation, live donor transplantation to a patient. But having said that, on one hand, you have a patient who is going to die without a transplant. On the other hand, you have someone who's willing to donate. So that is the basis, because you are talking about 100% mortality of a patient, whereas you are taking a small risk of donor to save that patient with 100% mortality, and that is the basis behind living donor organ transplantation. I think that should be okay, Barbie, just to, as a start about live donor liver transplantation. We can
Rohan, can I interrupt you? Rohan, what about the regeneration of the donor liver once the hepatectomy is done?
Yes. So basically, the beauty of the liver is that you can remove about 80% of the hair in the liver without a problem. Especially in cancer surgeries, we remove almost up to 80% of the liver, just leaving behind about 20%, and that 20% will regenerate in about 3-4 weeks time. But in donor hepatectomy, we don't go up to that extent. Generally we are happy to take about 40 to 45% of the liver, leaving behind about another 55%. But there are certain instances that we might harvest about 60% of the donor's liver without a problem, without a problem to the donor. But then all these surgeries are very complex operations, and any operation, no matter how much you are careful, one day you are going to end up in, there's a chance that you might end up in complications, and these complications can be fatal. And that is why we are very careful when we are selecting a donor for liver transplantation. But you are doing this surgery for a patient who has 100% mortality without a transplantation.
Thank you, Rohan. We're going to focus from here on. We are going to focus on the pediatric population requiring liver transplant, and to take us through the selection process and risk stratification of the recipient, I invite Dr. Miranti Fernando, the pediatrician, the consultant pediatrician who's in charge of the pediatric liver transplant program.
So let me talk a little bit about the recipient selection. So in pediatric population, I talked a little bit about their disease spectrum, what kind of diseases they come in with. Compared to adults where they have cirrhosis due to alcoholic liver disease, due to various metabolic liver disease, or maybe due to non-alcoholic fatty liver disease, children it's quite different. And majority of population come with biliary atresia. If I see 10 children, maybe 8 or 9, they have got biliary atresia. That's the commonest indication, in the sense the disease, underlying disease, which would require liver transplantation in children. Apart from that, there were other indications and diseases, which I mentioned earlier. So in this part, I would like to highlight few facts about recipient selection, because it's very crucial to identify which child and which stage, which family, which center. All these questions are very crucial to give a final outcome. So if you have a child with chronic liver disease, a very common complication among children, especially with biliary atresia population, if they develop recurrent or life-threatening cholangitis, that itself would become an indication for liver transplantation. Their synthetic functions may be normal, but when you look at the background, child has got 2 or 3 ICU admissions with septic shock due to cholangitis. Despite of the synthetic functions, we would consider that child as a candidate for liver transplantation. That's why I repeatedly say we don't really go by the numbers, but the indications would become quite different and individualized. And medically refractory pruritus, especially with genetic disorders of bile synthesis and transport, the classic symptom and the debilitating symptom they get is pruritus. And sometimes that impairs their quality of life and their development, which is very crucial in childhood. So medically refractory pruritus would become an indication for transplantation in isolation. Severe growth retardation or severe fat-soluble vitamin deficiency. If the child is getting recurrent fractures or severe growth retardation, whatever you do with nutritional rehabilitation, child is not gaining weight because the liver is not working. So you really have to consider liver transplantation early, though their synthetic functions are quite marginal. though they do not have clear-cut decompensation for you to see. And hepatic osteodystrophy, essentially, again, the hepatic bone disease, including recurrent fractures. So those are the clear-cut indications. However, the important message is we would normally look at the overall child quality of life, growth, development, impact of the life from the liver disease, and importantly, the trends of the biochemistry. And listing criteria, the different scores and criteria available locally and internationally, and actually no standard which had been validated or agreed. So unfortunately, again, I can't share. These are the indications, so this is the score. After this cutoff, we'll be doing the transplant. It's not really like that. And I'm sure you must have heard about PELD score, and not used in every center, I would say. Certain centers, for them to prioritize their waiting list patients, they might use PELD score, but not in every center. Just to share my experience, in the center where I worked in United Kingdom, they did not even mention about PELD score in even single MDT meeting. So it's about unit's policy and your experience and your expertise and basically your thoughts about the final listing. But however, it will be MDT discussion and decision in the end, not a single person's decision. Maybe some people or some centers, they do like to use certain scores just to streamline things, or maybe if they have a high patient load. Normally, we do not have a very high patient load waiting for transplant in pediatric liver centers. Normally, it's manageable. That may be the reason we still go by the subjective criteria. And the other fact may be we can't really extrapolate the scores and the information we get from adults, because the PELD was developed later from MELD, which was designed for adults. But in children, it's really different, where their growth, development, quality of life, and their biochemistry all are different. So we can't really extrapolate that data and make a score. So just to conclude that aspect, I would like to say, from pediatric hepatologist perspective, when you select a recipient, you have to make sure, firstly, is there any contraindication? Then, okay, if that is not there, okay, then you know the background disease, this is something transplantable. So is the timing correct? That is very crucial. No, not too early, not too late. So it's very important to monitor the trends very closely and identify the correct timing. And then you can bring up the discussion in MDT setup and get everybody's opinion and then list the patient. So I would briefly mention about transplant assessment when it comes to recipient selection and listing, what it means. It's very important, and I think it's an area which is often overlooked. The transplant assessment starts from the point where the child is identified as a potential candidate for liver transplant and to the point of the transplantation surgery. Once you have identified a child needing liver transplant and you have excluded contraindications, and then you have thought, okay, in our setup, with our expertise and with the other socioeconomic backgrounds, this is doable, then you put them on transplant assessment, where you will look into all the finest details of medical, social, psychological, all the aspects in order to optimize them prior to transplant. That's where you get your MDT team, all surgeons, anesthetists, psychotherapists, psychologists, nutritionists, everybody. I'm sorry, I'm not going to mention all the names, but all of them are important. So your entire MDT team will come into play in view of optimizing this child for transplantation. So that is where the transplant assessment. So before concluding in recipient selection, firstly, you have to make sure this child needs a transplant, maybe chronic liver disease, maybe acute liver failure, correct timing, correct child, not too early, not too late, and then finally think about contraindications and your MDT team support as well. I think that's all I have to say.
Thank you, Varanti. Our patient, the little girl who was referred to us was very fortunate because she was referred to us before it was too late for transplant. And it was at that point that the transplant, the hepatologist and surgeon referred the patient to us. To take us through the pre-op assessment, I would like to invite Dr. Nilmini Munasinghe and Dr. Nadisha Valikala, Both are postgraduate trainees in anesthesia with special interest in transplant anesthesia and critical care. Thank you.
Thank you, sir. I'll be discussing about the preoperative assessment in these patients, which is very important topic because of the increased risk of perioperative mortality and morbidity during liver transplantation. It requires multidisciplinary input, and thorough history examination and investigations are necessary to optimize these patients. Especially the cause of the liver disease needs to be evaluated in the pediatric population, as there are many causes, including genetic, metabolic causes, malformation, and tumors, which individually may have other organ involvement. Other than that, severity of the liver disease and the complications of chronic liver cell disease are important, and we need to look into the features of decompensation such as jaundice, hepatic encephalopathy, ascites, varicose bleeding, and spontaneous bacterial peritonitis. The pathophysiology of decompensated cirrhosis is complex. There is impaired function of the liver, which leads to multisystemic manifestations. Reduced removal of toxins and metabolites leads to jaundice and hepatic encephalopathy. Increased vasodilatory compounds give rise to vasodilatation and cardiovascular dysfunction, and they basically have a hyperdynamic circulation. Other than that, reduced intravascular volume with cardiovascular dysfunctions leads to increased renal vasoconstrictions that can lead to hepatorenal syndrome. And impaired synthetic functions of the liver can give rise to hypoalbuminemia and coagulopathy. Portal hypertension leading to varices and ascites, and immune dysfunction increase the risk of infection to patients with chronic liver cell disease. So all these aspects are important in our preoperative assessment. So as I said, there are multisystemic manifestations. In the cardiovascular system, what we need to know is special importance is the portopulmonary hypertension, which is rare in pediatric population. And if it is present, it is mostly due to Alagille syndrome. And these pediatric population, there can be associated other cardiac malformations, such as biliary atresia is associated with ASD and VSDs. And our child also had ASD, which required a device closure. It is important because intracardiac shunts can give rise to paradoxical air embolism, especially during the reperfusion phase of the liver transplant. Other than that, respiratory compromise and hypoxemia can be there due to diaphragmatic splinting due to ascites and hepatosplenomegaly, which might causes hypoxia, especially during intubation process because of the reduced functional residual capacity. Other than that, recurrent chest infections and pleural effusions and pulmonary edema can be present. Hepatopulmonary syndrome is uncommon in the pediatric age group. If the cause of liver disease is cystic fibrosis, there may be significant chronic respiratory involvement in this age group. Renal dysfunction is uncommon except in retransplants or patients who have given nephrotoxic drugs beforehand. And hepatorenal syndrome is also a bit uncommon among children, unlike in adults. Hematologically, there may be anemia, thrombocytopenia, and coagulopathy versus thrombosis, which will be discussed by our next presenter. There are growth impairment and poor nutrition among patients with chronic liver cell disease. Muscular deconditioning and frailty and malnutrition can affect the postoperative period, as well as our early intubation might be delayed if there's significant musculoskeletal decondition and frailty in this patient. And metabolic bone disease may be important during anesthesia in view of positioning the patients, because they are at risk of fractures. Infection screening and vaccination has to be updated before the transplant process, and all live vaccination has to be given at least 2 weeks prior to the surgery. So investigations involves basic investigations, clotting studies, and electrolytes and renal functions and liver functions. Specialized investigations to identify etiology needs to be looked into, and imaging depending on the surgical requirement. There are a few risk assessment scores that can be used, but they are not very specific in the pediatric population. As Dr. Meranti told earlier, PEL score can be used for children younger than 12 years of age, but the recent study has demonstrated the PEL score significantly underestimate the actual 90-day pre-transplant mortality, and they have seen increasing PEL score is associated with increased transplant benefit, and PEL score more than 17 have a survival benefit after liver transplant, and our patient had a PEL score of 19. MEL score is mainly done in adult patients, and score more than 15 should be transferred for transplant evaluation. MEL sodium score is also another risk assessment tool that we can use because hyponatremia itself is associated with increased platelet mortality. And there are multiple causes that the sodium can be low in liver disease patients, and it is mainly used for patients with higher MEL scores for a better risk assessment. That concludes my part of the preoperative assessment.
Alisha, can I interrupt you?
Yes,
what do you mean by a transplant benefit?
Transplant benefit is they have found out that with the MEL score, if the MEL score less than 15, it is associated with high post-transplant complication. So the transplant has to be done, is preferable, is done in patients with MEL score more than 15 because the risk of transplant is higher than the survival benefit if the MEL score is less than 50.
Thank you. So we've gone through the assessment of the donor and the recipient, and we move on to the preparation stage of for the transplant. In the case of this pediatric liver transplant we are focusing on, we didn't have proper theaters. We needed 2 theaters side by side for the donor and the recipient. A lot of things needed to fall in place before we could proceed with this. Funding was inadequate because this patient was from a very poor socio-economic background. There was crowdfunding for this transplant. We needed additional equipment. We had to borrow equipment from the Late Regional Hospital, and 6 other corporates contributed generously. And crucially, we needed intensive care support. We had issues with our intensive care unit at that point. So we had to seek help from the private sector, and private sector hospital very generously agreed to look after this patient free of charge. Nilmini, do you have anything to contribute to this? Because I know you played a huge role in getting all the support required for to make this happen.
Yes, Pandya. I think this had been a nightmare for us from 2011 when we started liver transplantation at our hospital with the team. And unfortunately, the first surgeon, I still remember how we started it in the middle of nights, long hours, finding theaters, going behind people, requesting for theater time. So, and all the senior consultant anesthetists who were here also have been supporting that, providing with medical officers. We had very limited number of trainees at that time. So it has been a struggle through for 9 years to come to at least this stage. So the main problem is we don't have dedicated theater time. So we need to always get the theaters organized with other surgeons. Especially if you are doing a live donor transplant, it's having 2 theaters running at the same time. The only complex we had was the GUGI complex where we could do it, because our new complex we are hoping that we'll be able to open it soon. with better infection control facilities. So one thing that we were thinking and we were worrying about is long hours and infection control measures inside our usual theaters. So we used hydrogen peroxide vapor sterilizer to have no-touch sort of technique of sterilizing the theater overnight, so that we tried to give up the best possible infection control measures in the theater. And we tried to limit the number of people who were coming. It was quite difficult because everybody wanted to come and have a look at what's going on. It's the first time that we were doing something like that. So crowd control was not very easy, but I think logistic-wise, finding even from suture material, I think surgeons, I know how much trouble they go through to find all the things that we need. So asking people around from other hospitals and the pediatric team that helped us, they also borrowed, we could borrow a lot of stuff that we needed from their hospital. And we should also remember the companies who generously allowed us to use their cardiac output monitor and other things. Without their help, we wouldn't have been able to have this successfully done. So I think logistically it's a nightmare all the time.
Thank you, Rimini. I think we need to, at this point, appreciate the contribution of the nursing staff, the other departments like hematology, the blood bank, the laboratories, the junior staff who helped make this, the ICU staff at the private hospital, who all contributed to make this possible and make it a success. I need to take this opportunity to thank everybody, the nurses, the ICU staff, the junior staff, the blood bank and the labs, and everybody else who helped to make this possible. Okay, we move next to the crucial part of anesthetizing the sick, cirrhotic child. It was a totally new experience for us. We need to get two experts from Lady J Hospital, the pediatric cardiac anesthetist with lots of experience in managing children to come and help out with this procedure. I would like to request Dr. Chamila Liyanagi and Dr. Dakshi Jayavikrama to explain how they anesthetize this patient for a liver transplant. Thank you.
I'm Dr. Dakshi Jayavikrama, consultant anesthetist from Lady Ridgeway Hospital for Children. And I'll be talking about anesthetizing a pediatric patient, mainly concentrating about older children and not neonates or infants. So children are not mini adults. Now they have special characteristics. Anatomically, physiologically, and pharmacologically, they are different from adults. Anatomically, they are more prone to have difficult airway because of their different anatomy from adults, and difficult venous access as well as arterial access. Physiologically, they have increased metabolism, heart rate dependent cardiac output, decreased blood pressure, decreased functional residual capacity, among other things. Pharmacologically, they have a rapid induction and recovery from inhalational agents. They have a high MAC value and abnormal drug metabolism due to immature organs. And children are at a higher risk of anesthetic morbidity and mortality. And this risk is inversely proportionate to the age. Anesthetic management itself is different from adults. And special considerations should be given to airway emergencies as well as emergence delirium. So preoperative assessment and optimization. So it's important to build a good rapport with the child as well as with the parents to allay their anxiety and fears. So history has to be taken from the parent, and so is the consent. Older children may be able to give a good history. Then we need to concentrate on pre-existing any medical conditions or any syndromes. As it was said earlier, vaccination history is important, and they are more prone to get upper respiratory tract infections. So airway assessment is a must because of a high chance of a difficult airway. And pre-medication, we normally do not pre-medicate children, but if it is indicated, sedative drugs can be given with monitoring. If you look at investigations, unless for a major surgery or specifically indicated, a lot of investigations are not required. So intraoperative management. Before we take the patient into the theater, we need to get ready with the pediatric equipment. This includes airway equipment as well as monitoring equipment. And we need to optimize the operating theater temperature as they are more prone to get hypothermic, especially if it's a major surgery. 2 competent anesthetists should be present. And of course, drugs should be made according to body weight. And depending on the age of the child, older children would prefer to have the parent at the induction. So induction itself, it could be IV or inhalational induction. And maintenance of anesthesia, post-operative management depends on the type of surgery. So that's anesthetizing a pediatric patient in a nutshell. Over to you, Bhagya. Thank you.
Actually, if I may ask you, being cardiac anesthetist, one reason we invited you was because you were highly experienced cardiac anesthetist, both of you. So, what
Yes.
about IV vascular access? You said vascular access is notorious difficult in these patients. What kind of vascular access do you have in this patient?
Well, these major surgeries, we have, other than the peripheral vascular access, we need to have a central venous access, as well as actually 2 central venous lines, as well as arterial lines. We do this under ultrasound guidance, which is helpful, especially in pediatric population. So, yeah.
Thank you, Dakshi.
Good afternoon. I'm Dr. Chamila Liyanage, one of the pediatric anesthetists at LRH. Actually, I'm going to continue Dakshi's presentation. Anesthetizing a pediatric patient with liver failure for liver transplant is a challenge. As Dr. Dakshi already mentioned, children are not mini adults. So, anesthesia for liver transplant should be thoroughly individualized based on hepatic disease, etiology, related cardiac conditions, hemodynamic instability, electrolyte imbalances, and amount of ascites, as well as the history of GI bleeding. But there are many common concerns to be addressed. Most of the concerns are already addressed, but I would like to add more about, other than the cardiac assessment, renal, liver, and the lung assessment, we have to assess their dental status, because dental infection directly affect the outcome of the liver transplants, as well as the immunization. Psychosocial assessment, because transplant places immense emotional and psychosocial pressure on both baby and the parents. And then neurocognitive assessment is also mandatory, because at any time during surgery, there can be insults. So after assessing the patient, normally, as Dr. Dakshi told, we very rarely do investigations. But for these type of surgeries, we request all investigations. And it's always, we have to check whether they are at optimal levels. And the pre-op medications, yes, according to the hepatologist's advice, we should continue all medications. Very rarely we need pre-medication, but sometimes for very anxious babies, we might have to give oral benzodiazepines before taking them to the theaters. After parents' consent, only we should plan to do the surgery and prepare theater. Here is another challenge to convert an adult theater for pediatric theater. It's mainly based on the patient's weight, age, and then the height. And as Dr. Dakshi mentioned already, there should be at least 2 competent anesthetists throughout the procedure and the trained staff for pediatric surgeries. And pediatric monitoring, patients' warmers, and the control of theater temperature mandatory. And preparation of pediatric line insertion, the correct size according to the weight, includes CVP lines, bascats, arterial lines, urine catheters, NGs. And other than basic monitorings, we have to connect central line, CVP line monitoring, invasive arterial blood pressure monitoring, defibrillator pads, because we don't know when baby can get arrhythmias. And it's good to have DVT pumps. And the infusions. Very rarely in other surgeries, we prepare infusion pumps for prior to surgeries. But here, we prepare atracurium as a muscle relaxant, fentanyl or remifentanil for pain control, calcium, dextrose, and infusions for vasoactive agents like noradrenaline, vasopressin, and inotrope like dobutamine. It's very important to have fluid arrangements, especially albumin, and mandatory to keep at least 2 units of blood and 20 ml per kg FFP during the procedure. And also we have to consider to give warm fluids. And sometimes we might to give rapidly, so the rapid infusers. Monitoring charts, and we have to plan few investigations to be done during the procedure. They are arterial blood gases, rotum, full blood count for hemoglobin and platelets, coagulation profile, and sugar. After preparing emergency drugs and other drugs, only we have to take these patients to the theater. In normal conditions, we prepare only atropine, but in liver transplant, it is mandatory to be ready with adrenaline, ephedrine, even phenylephrine. And drugs like adenosine, esmolol should be, we have to plan whether we are going to do gas induction or rapid sequence induction. But sometimes, even though patients comes with the cannula, the patency of the cannula is done. And antibiotics you have to give according to the international protocol. And the patient positioning also should address before patient taken to the theater. After all, only we should take the patient with the parent to the theater. So it may be gas induction. So the best is sevoflurane because it is non-irritant. If there's an IV access, we can consider to give propofol or ketamine. So we do normal rapid sequence induction with adequate size of ET tube and then the insertion of NG tube. Maintenance of anesthesia is good to have isoflurane because it conserves the splanchnic blood circulation and dilates the hepatic vasculature and improve organ perfusion. But sevoflurane, desflurane also is ideal. For the pain control, as we have already mentioned, we should start fentanyl infusion. And to maintain the muscle paralysis, continue atracurium. OT monitoring is very important, as we have already mentioned the temperature control, because they are very vulnerable to get hypothermia during perioperative period due to malnutrition, high cardiac output states, peripherals are already vasodilated, and the massive surgical fluid. Not only that, actually, because of cold temperature of retrieved organs. they get hypothermic, their cardiac functions can affect, as well as receptor functions and then the coagulation. Other than basic monitoring, we have already mentioned, we have to have a thorough fluid balance chart. Normally we inserted, already Dakshi told that we insert 2 large bore lines in upper body, because when we clamp the IVC during anhepatic phase of the transplant process, there can be delaying timing for drugs to reach the central circulation. So after stabilizing the patient, after applying the defibrillator pads, and if we are happy only, we hand over these patients to surgeons.
Now focus on the chronic liver disease, the child with chronic liver disease who's being anesthetized. But before that, I would like to request Rohan and Suchinta to take us through the different phases of the transplant, liver transplantation surgery. Rohan, any thoughts on that?
So before starting to talk about the surgery itself, I can remember my trainer telling that this is surgery with 1,000 steps, and each step you need to remember, and unless you follow these 1,000 steps in proper order, you are going to end up in trouble. So it's a very complex operation, and you can't take your mind off the surgery until you from the point you start the surgery until you put the last stitch in the skin. You can't take your mind off the surgery. Easy operation I've seen, maybe 4-5 hours time you can finish the operation. But sometimes I've seen that, I have experienced myself, I've seen it happening to people. You keep on operating for hours and hours, even 24 hours, and maybe more than that, and at the end of the operation, the patient might die. So it's a very complex operation, and unless you are totally focused on the operation, the outcome may not be what you expect. So basically, you are talking about two here in this situation. You are talking about 2 operations happening simultaneously, one in the donor and the other one in the recipient. So what we do is generally we start the surgery with the donor, and we keep everything ready for the recipient. And we open up, keep everything ready. Once you anesthetize, you open up the donor and see whether everything is as expected, based on what you assess preoperatively on the recipient. Sometimes when you open up, you might find something unusual, and you might find that there are maybe peritoneal nodules of a metastatic disease. So until you are 100% sure that you can proceed, we don't take the recipient inside. So once everything is fine, then we start the recipient operation as well simultaneously. So donor operation, the special thing to mention about the donor operation is that unlike in cancer surgery you operate only on the patient. But when you are doing a donor operation in a donor hepatectomy, you are operating on the donor as well as you are operating on the recipient, even though you are not actually operating on the recipient, because the part that you are going to take out is going to save that man's life. So it's very important that you pay your attention on the recipient side as well as donor side. Whereas when you are operating on the cancer, you can just forget about the part that you are taking out from the body. But here it is different. And donor operation, generally we start with the hilar dissection, and we do a cholangiogram to confirm that the anatomy of the liver system is what you expected before the operation. And then we transect the liver up to a certain point. And about the liver transection, there's something very important that we should mention about as far as anesthesia is concerned, because we are not doing, generally when we are doing when we are doing hepatectomies, we either use sprinklers or you block the blood supply to the part that you are removing. But here we are not stopping the blood supply to the liver or to the part that we are removing. So it's very important that we maintain a low CVP in these patients. Otherwise, donor hepatectomy becomes very, very difficult and can be very messy. So, so we operate and we start the transection of the liver, and after a certain point we divide the bile duct, and that is the place where the surgery becomes irreversible. And it's very important that you communicate with the recipient side. Okay, now we are going to divide the bile duct, and we have come to an irreversible point, and you can time the surgery so that by the time you are taking the donor liver out from the body, the recipient is ready to accept that organ. So it's very important to coordinate the donor and the recipient sides. So once we complete the transection, after dividing the bile duct, we continue the transection. At the end of the transection, the liver is split into two parts, and the liver is the donor liver. The donor part of the liver is hanging with the portal vein that you are going to take. Let's assume in this case we took the left lateral or segment 2, 3, and we took segment 4. So we were at the end of the transection, the hepatic artery or left hepatic artery, the left portal vein, and the left hepatic vein were the only connection to the donor's body. So then you communicate with the recipient side again and say, okay, we are ready to take the liver out from the donor, and are you ready? So when we get the word, we keep the back table ready. So then we divide the portal vein, hepatic artery, and the hepatic veins, and then we take the graft out from the donor. And from here onwards, it's very important that your back table is ready when you are taking the donor liver out, and then we flush the liver with the organ preservation solution. Here in this situation, we used TK solution, which will flush all the blood that is in the liver, and then we look at the outflow of the graft. So that is the hepatic vein, and make sure that there is good outflow, that the hepatic vein has adequate diameter. And if we feel that it is not having adequate diameter, there are certain things that certain manuals, certain procedures that we may do to increase the outflow. So that's donor. So once the donor, then we'll move on to the recipient. And out of the two operations, recipient operation is technically much more challenging than a donor in certain aspects. Now, a donor or the recipient operation is special because you're operating on a diseased patient or a patient who can use. No matter how much you optimize this patient, there is a certain you can optimize them only up to a certain extent, and beyond that, it's very difficult to optimize them. And so they are started their organ reserves are very poor, and if you take long time for operation, sometimes the outcome may not be as much as good as in an operation I do with a short period of time, low blood loss. So so start with you're operating a difficult patient, and in these patients, because of the portal hypertension, you see a lot of varices around the porta hepatis, around the diaphragm. So dissection is very difficult, and these patients are sometimes, most of the time, they are coagulopathy. So we have to pay a lot of attention to dissection, and if you have to maintain a fine balance between the fast dissection and slow dissection. If you dissect it very slowly, then there is a lot of tight blood loss, and if you dissect very fast, then there is a lot of blood loss. So you have to maintain a balance, and probably you have to alter your phase of operation depending on the place that you operate in. So when you open up, the first thing that we do is we mobilize the liver. So the first phase of donor hepatectomy is explantation, and explantation, in certain instances, patient can lead to death. So I think as far as anesthesia is concerned, it's important to know in what parts the patient can die. So we, as surgeons, once you open up, we start the dissection with the liver, mobilization of the liver. And generally, what you mean by mobilization, you mobilize the liver from the diaphragm. And generally, you don't bleed to death when you mobilize the liver from the diaphragm, because you are handling very small vessels. But the problem is, it's very important to communicate with the anesthetists as surgeons what you observe in the surgical field. And sometimes you see that there is unusual oozing, because as surgeons, we detect that before the investigations, that you pick that out from investigations. So it's very important that as surgeons, we pick that up and communicate with the anesthetist. Okay, we are seeing something different in the surgical field, so just look into that, and that is very important, I think, for a smooth surgery. So we mobilize the liver from the diaphragm. There can be tiny varices which bleed, so you have to pay a lot of attention onto that, and you dissect up to the IVC, and most of the time we stop there at that point, and then we move the hilum. And hilar dissection is also can be very difficult, especially if the patient had spontaneous bacterial peritonitis, and then there can be tiny varices around in the hilum which can lead to bleeding. So again, when you dissect the hilum, generally our aim is to isolate the portal vein, isolate the hepatic artery, and isolate the bile duct. That is the aim of the hilar dissection. And sometimes when you are dissecting the portal vein, there can be tears if you're not very careful, and that point sometimes you can end up with crucial bleeding. But out of these, the next step, or the mobilization of the liver from the IVC, is the most important step. As anesthetists, generally I tell that, okay, we are dissecting the IVC because that is a place where you can end up in fatal bleeding. If you make a hole in the IVC, patient can bleed to death. So it's very important that everyone is aware, okay, if I'm dissecting around the IVC, we are dissecting around the IVC. So there are two ways of doing that. One is caval replacement. Here you actually don't dissect around the IVC, you remove the liver with the native IVC, and your recipient organ is a complete same image where you take the donor organ with the liver and the IVC, and you implant that into the patient. So that's a caval replacement. And the second type is a piggyback technique where, and this is what is difficult, where you remove the liver, leaving the patient's IVC, and then you implant the donor's liver with the IVC, and it's a site-to-site anastomosis, and that is what you call a piggyback. So in live donor liver transplant, you can't actually remove the recipient liver. You have to leave behind the recipient liver, and you have to dissect the recipient deceased liver from the native IVC, and that is what is difficult. So then once we complete the dissection of the IVC, liver from the IVC, then we are ready to accept, we are ready to remove the liver from the patient. And then it is very important that we coordinate with the donor team. Okay, now we are also ready to accept the organ. And then you clamp the portal vein, clamp the hepatic artery, and then you clamp the hepatic veins, and then you remove the liver out of the patient, and that is what we call the anhepatic phase. And this in this time, the patient does not have a liver inside his body. And then comes implantation. And in the implantation, there are different techniques of implantation. I'll not go into details of that. Basically, our aim is to implant the organ or the liver, the hepatic veins into the recipient's IVC. There are different techniques of doing that, and the idea is to give a large opening of the outflow to the organ. And then the first step of implantation, the second step, the second step is the anastomosis of the portal vein of the recipient to the donor, and that is generally this takes about maybe around 35 to 40 minutes in a difficult patient, can go up to 1 hour. And this is the warm ischemic time where the organ is, or where the graft is inside the patient's body without a perfusion. And that is, you would try to minimize this time, because this is the killer, and if you take long time, there can be a lot of impact on the graft. And then generally, few minutes before completing the portal vein anastomosis, generally we used to tell, okay, in about a few minutes time, we are ready to perfuse the organ, and then the anesthetist gets ready with the problems that you might face during the organ reperfusion. So then once everything is fine, then we first open the clamp in the outflow, and then we see whether there are any major bleeders, and then you take out clamps in the portal vein. And then this is a time that as anesthetists and as surgeons, we are all anxious when the patient gets reperfusion or related complications. I think probably someone might talk about it. So this is the time that you are very worried whether your graft is going to get an initial hit. And then once the patient is stable, Generally we take a small break, and then we start anastomosis in the hepatic artery and the bile ducts, and that is how it completes. And out of these two, especially in pediatrics, hepatic artery is very, very important because the size of the diameter of the hepatic artery, especially if you are doing a live donor transplant, it's about 2-3 millimeters, and it's one of the most challenging anastomosis out of all the anastomosis. It's hepatic artery in pediatrics that you are really worried. So that's briefly about the surgical aspect of the transplantation.
Thank you, Rohan. We will digress for a short time. We'll get the anesthetist to talk about the anesthetizing the donor, and then we'll come back to the recipient. Dr. Oliver Padmakarama, acting consultant anesthetist at Chilao, and Dr. Rachini Vitanage, senior registrar in transplant anesthesia and critical care, attached to the Bulgaria Base Hospital, will take us through that. Thank you.
Thank you, Bhagya sir. First of all, I would like to speak something about the importance of proper donor management. Donor undergoes technically complex procedure with high risk and no direct benefit to him. So as Prof. Rohan Sirivardhana mentioned, this is a totally healthy, completely healthy patient who has volunteered to donate part of his liver, risking his life. And this raises serious ethical issues such as do no harm and non-maleficent. Basically, this is why the proper donor management becomes extremely important. The donor surgical mortality risk is around 0.15%, and it is absolutely necessary to keep our donor mortality rate within the acceptable levels. And obviously, ultimate outcome would be good quality graft, which will affect the recipient outcome. Going to pre-op assessment. Pre-op assessment is mainly focused to select a suitable donor. Donor selection criteria differs in various centers. Basically, ASA1 candidates are prioritized, but there are extended criteria in different units. Apart from patient assessment, the donor is prepared both medically and psychologically for this major surgery. Pre-op assessment and management should be multidisciplinary, including independent medical, surgical, and psychiatric inputs. There should be always a good communication between these teams. The donor undergoes extensive stage assessment and investigations by liver transplant team, including health screening surveys, blood tests, viral serology, and imaging studies. The surgical team will do a detailed anatomical evaluation of liver related to segmental anatomy, vascular and flow anatomy, bile duct anatomy, and drainage. It is also important to decide on volume of remnant liver and expected graft volume. The volume of remnant liver should be more than 30% of the initial liver volume for the donor survivor. Other than these aspects in pre-op management, it is utmost important to provide accurate medical information to the patient, particularly on post-op recovery and potential complications. So our patient was a 38-year-old female who was the recipient's mother and was a ASA1 patient who underwent this thorough pre-op assessment and investigation and found medically and psychologically fit for the donation. So the intra-op management part would be discussed by Dr. Oliver. Over to you, Dr. Oliver.
Thank you, Rachini. Thank you, Bhagya sir and Prof. Rohan. And I will briefly go through the some important aspects of intra-op donor management. as already Rachini has explained, this is a healthy individual who comes forward to give a life to the recipient. So we have to make sure that the donor's safety is assured to the level best, and the possible complications should be detected early and minimized. So our main objectives are threefold: donor safety assurance and the avoidance of complications, and assurance of the quality of the graft, and achieving a smooth recovery and extubation in operating room preferably. So to achieve this, we need to have a good monitoring system, and establish a good communications between the surgical team, and have a good understanding about each step of the surgery, and need to follow that up. The steps have been already discussed and described by Prof. Rohan, and I will tell you some common complications we need to pay more attention. The excessive bleeding, that is hemorrhage requiring excessive fluid therapy, blood and blood product transfusions, and use of excessive vasopressors, which will be unfavorable for the patient, remnant liver, and for the graft. So we need to avoid excessive blood loss. There are many steps I will discuss later in shortly, which we will adapt to reduce bleeding. The metabolic derangements, usually the lengthy and major surgery, the metabolic derangements are highly possible, like metabolic acidosis, hyperlactemia, and hypercalcemia, and different glycemic changes. And the next one is the sepsis. And with the spillage of bile and lengthy surgery, the patients, although they are young, they are prone to infections. The organ dysfunctions. The patients can have the acute kidney injury and remnant liver cell injury, and later move into dysfunction and even failure if you don't pay attention on it. And then the other complications are like hypothermia, position related nerve injuries, especially brachial plexus injury, and rare but serious complications which one should need to pay more attention and detect early and react, like air embolism, pneumothorax. So when I come to the next topic, the monitoring, we adopt standard monitoring plus some extra invasive monitoring like intra-arterial blood pressure monitoring and central venous pressure monitoring. And also this particular patient, we took little extra precautions and we went ahead with cardiac output monitoring also with transesophageal echo monitoring. And then blood gases, you do frequent blood gases, baseline levels, then before transection start and during transection like every hourly, and then before the graft being retrieved and after fluid resuscitation, and before extubation and after extubation. And we make sure the patient's metabolic status derangements are detected and corrected to acceptable levels. So the next, the important thing at the beginning of surgery is to make sure the patient, the donor, is getting a meticulous and adequate analgesia level. So that we start with other, like in the other surgeries, we start with preemptive analgesics like gabapentin preoperatively. And before surgery, the gold standard is the epidural analgesia. We establish mid-thoracic epidurals before the induction. But in our patients, we went into intrathecal morphine since the patient's coagulation, one parameter was little at the margin. The APDT was somewhere around 37. So we deferred the epidural and used intrathecal morphine. And the other options are tab blocks, subcostal, bilateral, or unilateral. Newer technique which is becoming popular is erector spinatus block. Usually it's given bilateral and the catheter is inserted for the post of use. And the other options are IV opioids. Like we prefer to use short-acting remifentanil, short-acting agents like remifentanil or fentanyl. This particular donor, we use remifentanil infusion, titrated to achieve an adequate level of analgesia detected clinically. So then the next important topic is the reduction of blood loss. And so the reduction of unnecessary fluid infusions and reduction of heterogeneous blood transfusions, so that we are hoping to reduce the whole list of side effects of administering fluid and blood products. So in this regard, the common technique employed internationally is low CVP. So this patient also we maintain during dissection phase and during transection phase, especially a low CVP, somewhere around 0 to 5, and stroke volume variation also maintained little at the higher side, somewhere around 12 to 18%. We looked at the stroke volume variation which was displayed on the transesophageal monitor, as well as pulse pressure variation which we got on the main patient monitor, which had a almost nearly equal, which gave the almost nearly equal numbers. Then the other options, and there are other various techniques we also employed to maintain low CVP, like restrictive fluid therapy and the ventilator techniques, low volume ventilator, the tidal volumes, and patient positioning. And although we didn't use the use of furosemide and vasodilators like GTN, also could have been used with caution and various implications. But in this patient, we didn't have to use any of those. And then other techniques would have used and used in other patients, but not in these patients, are homologous blood transfusions, including pre-donation and acute normulemic hemodilution, which I have used earlier for some other patients, but not in these patients. Since this was a pediatric transplant, we took the left lateral lobe and we didn't expect a big blood loss in this patient. So the next question is, what fluid to be used? So the best fluid is supposed to be a balanced crystalloid, the plasmolite, which is being used by other centers commonly, but unfortunately in Sri Lanka we don't have that. We went for rigorous lactate solution, which is a buffered solution, buffered with lactate, and knowing that the lactate has some other side effects here, because lactate is being metabolized by the liver. With a small remnant liver, lactate metabolism will be defected, and lactate as indication for the hypovolemia, poor perfusion, and the liver dysfunction, all can be affected by using a lactate containing fluid. Knowing that, we carefully used ringer lactate based fluid. And then also we used when it comes to the colloid, the use of hetastarch gelafuscin. Gelafuscin is controversial because of its detrimental effects on major surgeries, and the evidence that found in cardiac surgeries and critically ill patients, which will end up with multi-organ dysfunction and coagulopathy. So because of that, we didn't use any of those colloids, and we use 4% albumin in heart-burn. Having said that, the recent evidence is not supportive of that. Since the liver donors are healthy donors, the hetastarch gelafuscin has been used in many studies successfully. So at the end of the at the end of the transection, we resuscitated the patient adequately. Once the transection is over, we resuscitate the patient successfully to the level we want to normalize the patient's parameters and the volume status. And then other important aspects are the anomalies expected in blood gas, which I have already discussed, and the metabolic acidosis, lactate levels, hemoglobin, calcium levels being corrected appropriately by monitoring closely. Use of bicarbonate was found to be very cautious. In this patient, we didn't have to use bicarbonate to correct acidosis since this patient didn't show much acidosis. And other important aspects are position-related injuries, hypothermia, DVD prophylaxis, sepsis, and the sepsis was prevented with pre-prophylactic antibiotics. We used meropenem, and if we use something else like a positive cover, we can use amikacin-like thing at the time of cannulation of the bile duct for intraoperative cholangiogram. And finally, and also we have mentioned that to maintain blood pressure so that the perfusion during the restrictive fluid therapy, we use small dose of noradrenaline with a caution, not to administer in high doses since its detrimental effects on the patient's organs as well as the graft. Finally, I would like to say that something about what we did to assure the quality of the graft. So we made sure that the patient's mean arterial pressure was maintained and the graft and the remnant liver perfusion was maintained by using the fluid cautiously and maintaining the blood pressure with vasopressors, and same time we avoided high doses of the vasoactive agents, noradrenaline, and administration of unfractionated heparin. Intravenous 5,000 units were done 1 to 2 minutes before clamping of the graft vessels. So this is these are the important aspects we paid attention during the donor intraoperative management. Thank you.
Thank you, Oliver. Thank you, Rajini. We move on to the anesthesia for the recipient. As Rohan discussed, the transplant itself can be divided into the pre and hepatic or the dissection phase of the explant. The second phase being the anapatic phase when the patient is without liver. This lasts about 30 to 45 minutes. And then finally the reperfusion phase where you're faced with, as anesthetic, you're faced with all the reperfusion phenomena which you have to deal with. So to take us through that, we have Dr. Nilmini Munasinghe, who's a senior registrar in anesthesia with special interest in transplant anesthesia and critical care, who's been trained at Leeds, one of the premier transplant units in the UK, to tell us about this. Thank you.
I'm Chamila again. Now let's start the pre and hepatic phase. Actually, this is the beginning of our race. So there should be a good start to get a perfect win, right? So to do that, to achieve our goals, we have to, for that actually we have goals to be achieved, right? The first one is to maintain hemodynamics. We have to measure blood losses and blood pressures. And if according to that, the meticulous fluid, giving fluids like 5% albumin or the ringer lactase, or maybe blood or blood products, plus using vasopressors is mandatory. And then the second issue is to avoid acidosis, because already compromised liver, that can affect patient's coagulation, cardiac functions, and then the patient deterioration. Thirdly, we have to avoid any electrolyte imbalances. During this period, it's mandatory to maintain normal potassium, calcium levels. Maintaining his normothermia is a challenge from the beginning of the surgery. So the proper temperature monitoring, fluids through a fluid warmer, and the external warming devices should be attached. And the maintaining normal glycemia is also mandatory because affected liver patients normally get hypoglycemia. So how to monitor those things? Because of that, in this phase, normally we do blood gas, a rotum, a full blood count to check the hemoglobin levels and the platelets, and a random blood sugar, and then the coagulation profile. As already Roshan has mentioned, the communication between surgeon and the anesthetist is very important, because even a 1 second can change the patient's parameters and the outcome. So it's always better to have the proper communication regarding patient status as well as the surgery. It's good to have low CVP measures during this phase, but it is sometimes challengeable because of the surgery, which causes abdominal pressure. So that's all about actually pre and hepatic phase, and hope that Nilmini will continue and hepatic phase.
Thank you, ma'am. Thank you. So the anhepatic phase usually starts with the interruption of hepatic blood flow and ends with the reperfusion of the new liver. So order of interruption of the blood flow is clamping of the inferior vena cava superiorly and inferiorly, and clamping of portal vein and hepatic artery. Then the deceased liver is removed and the new liver fits in. So during this phase, the particular challenges we face are maintaining mainly the hypoglycemia, because there's no virtually functioning liver at the moment in the body, and also hypocalcemia, and we have to prepare for the reperfusion. Those are the three main challenges we have to manage during this phase. So hypoglycemia management, of course, can be done in many centers. They do start with a 5% dextrose infusion from the beginning and run it up and change the concentration accordingly depending on the deficit into 10% and 25%. But the more rational way to approach is monitoring the glycemic levels and managing accordingly with slow bolus infusions of higher concentration of glucose, because that reduces the amount of hypotonic solution we give to the patient, especially in pediatric liver transplants. Hypocalcemia is a result of bleeding. Therefore, we have to top it up and preemptively correct, or sometimes overcorrect a little bit towards the high side. This is just to help mopping off potassium during the reperfusion period. So we have to prepare for the reperfusion by topping up calcium with infusions and preparing all the drugs which are needed for reperfusion, such as calcium, sometimes magnesium to manage arrhythmias, and also inotropes and vasopressors and bicarbonate to manage any acid-base imbalance. And also during this period, we have to be ready with this sufficient supply of blood and blood product in theater, and the fluids to be mounted into the rapid infusers. So that is the anhepatic phase. So we try to maintain the normal physiology throughout this phase. Then we come to the reperfusion. So this is the most challenging phase for the anesthetist, I would say. So during this reperfusion, all these, there's a huge hemodynamic instability which occurs as a result of ischemia reperfusion injury. So that will give rise to severe hypotension, bradycardia, bizarre arrhythmias, supraventricular tachycardias, complete heart block, ventricular arrhythmias, even asystole. All these arrhythmias are responsible due to hyperkalemia surge, which occurs in as a result of ischemia reperfusion. And also air emboli, which are uncommon but possible in these case scenarios, that will further worsen because they can cause acute right ventricular failure. And also the bleeding. So especially if that is a live donor, this bleeding can be problematic if the new liver has a raw surface from the cut down. So those are the challenges we face during the reperfusion period. So as I told you, the hypotension is the most detrimental thing that happens soon after reperfusion, soon after the clamp release of IVC and portal vein. So this is of course multifactorial. One is due to the bleeding itself and also due to the ischemia reperfusion injury associated vasodilation, arrhythmias and stunning of the myocardium. So we have to treat each of the component accordingly with fluids, especially the blood and blood products, and normalization of electrolytes to alleviate the effects of arrhythmias, and using inotropes and vasopressors to help the myocardium and the vasculature, and also add additional calcium because that helps the myocardial protection. And another phenomenon we observe is the acidosis in terms of hyperlactatemia. So acidosis occurs as a result of release of acidemic blood upon IVC clamp release. So this may continue for a while till the hepatic artery also being anastomosed, because that is the full reperfusion phase we anticipate. And then that slowly normalizes, which gives a promising result for us to see the new liver is working. Then we come to the neohepatic phase or the post-reperfusion phase. So during this phase, we have to normalize the patient's physiology basically. So we have to normalize the volume. Sometimes we might have given a little bit of extra fluids. So better to beware of over transfusion, and then correct all the abnormalities such as acid-base imbalance, and most importantly, hypothermia and the coagulopathy. And we have to prepare the patient for next step, which is the extubation or fast tracking. So thank you. This is the anesthetic considerations and anesthetic challenges during the different phases of pediatric liver transplants. Thank you, sir. Over to you.
Nilmini, you spoke managing hypovolemia and hypotension in this phase.
Yes.
It's a very difficult balancing act because the patients will bleed, the patients will become hypotensive, so you need to give fluid. But at the same time, you need to avoid over transfusing, overhydration, because the congestion of the right atrium or overfilling of the right atrium could lead to back pressure on the inferior vena cava, and hepatic venous outflow can be obstructed, leading to dysfunction in the new liver. So how do you balance this? How do you manage to do this?
I think that is the next bit of my presentation. So we have to stay ahead of the game and anticipate these problems and manage preemptively all these issues. So the key concern we had during managing this case scenario is particularly the hypothermia associated bleeding, catastrophic sort of bleeding and hemodynamic instability. So guiding our fluid should be done with the goal-directed fluid therapy. So that, of course, I think I'll discuss that in my further discussion. Is that okay if I continue for that, sir?
Continue.
I would like to add something for Nilmini. Actually, the preparation before clamp off is mandatory with
of course.
emergency drugs, and then the mannitol, furosemide, and fluid boluses, because
of
that's
course,
one of the crucial points we face.
Yes, during the anhepatic phase, we have to prepare for the reperfusion scenario. Okay, so staying ahead of the game or fast tracking of the patient is a key challenge we face during pediatric liver transplants. So what are we staying ahead? What are we anticipating? Those are managing mainly cirrhotic coagulopathy, managing fluids rationally, and anticipating and ameliorating ischemia reperfusion injury, and ultimately targeting fast-track recovery. So staying ahead of the game and fast-tracking of the patient, it was a key challenge in managing this pediatric liver transplant. So what were we staying ahead of, or what were we anticipating and managing in order to minimize the complications? Those were managing cirrhotic coagulopathy, managing fluids rationally, anticipating and ameliorating ischemia reperfusion injury, ultimately targeting towards the fast-track recovery of the patient. So when talking about cirrhotic coagulopathy, the state of the clinical art of coagulopathy in cirrhosis has considerably changed over the last decade, because earlier it was considered as an epitome of hemorrhagic construct. But now, during the last decade, by means of great deal of studies, the concept has now considerably changed to a fine, rebalanced hemostasis with minimum reserves of coagulative factors, and both the procoagulant and anticoagulants, and more towards a mixed or a prothrombotic paradigm. So it's a considerable shift of paradigm. So this rebalanced coagulation can be even more prothrombotic. Therefore, the conventional coagulative testing, such as PTINR, APTT, are not practical enough to be used in managing these patients, because they are overly simplistic, as well as sometimes overcorrect the coagulopathy, leading to prothrombotic complications. And also this fine balance is easily disrupted by other factors like hypothermia, acidosis, and bleeding, where we experienced that in our case scenario, because the patient was hypothermic during an hepatic phase and required a lot of effort to bring back the temperature back to normal, because that led to a significant coagulopathy, which was not evident in point of care testing, point of care coagulative testing. So we had to basically correct the hypothermia in order to minimize and reduce and optimize the bleeding. So, then that is the point where the point of care vesicoelastic testing come into play. And they have revolutionarily minimized the traditional massive blood loss associated with liver transplants. And therefore, they are vital in decision-making, especially in transfusion of blood and blood products. So we use ROTEM, which is rotational thromboelastometry, as our point of care coagulation test in managing this pediatric liver transplant. We've experienced some advantages as well as disadvantages. As a privilege, we had a consultant hematologist in hospital who volunteered to interpret the results, which helped us immensely in managing our decision-making of giving blood and blood products. But at the same time, it took unnecessarily prolonged time to get the results from the lab to us, and also getting the communication done with regard to get the interpretation results. So that causes undue delay in decision making. Not only that, the analyzer we had did not have a platelet analyzer, platelet function assay in this ROTEM. Therefore, we had to do recurrent full blood count to see the platelet count as well to manage the coagulopathy. Therefore, our transfusion strategy was mainly based on clinical sense, close communication with the surgeon, and looking at the surgical field, which was the traditional thing we have been doing for last couple of decades. So the bottom line is, we face a dire importance of on-site point of care testing in managing liver transplants, especially pediatric liver transplants. Then comes to the goal-directed hemodynamic therapy. So these are pediatric patients, we cannot overload them, but liver transplant is a surgery that is associated with huge fluid shifts. So therefore, and also it goes without saying that these patients, cirrhotic patients, are having hyperdynamic circulation with underlying sometimes cardiomyopathy as well. So therefore, it is essential to monitor the hemodynamic parameters to guide our fluids. So we use this non-invasive cardiac output monitor. And by means of that, we were able to measure the stroke volume variation, contractility, afterload parameters like stroke, systemic vascular resistance. And also not only that, we measured the central venous oxygen saturation with the blood gas and the lactate levels and hemoglobin and hematocrits to guide our fluids. So it was a collective decision to guide our fluid based on these hemodynamic parameters. And then, since this surgery is associated with huge fluid shifts, there was dire need of giving fluids rapidly. Therefore, the rapid infuser helped us immensely in managing these hemodynamic instabilities. But there are advantages as well as disadvantages. The advantages means we could give rapid boluses that would rapidly correct the hemodynamic imbalance. And also it warms the fluid as well and helps in hypothermia correction. But the disadvantages being these fluid infusers were not calibrated for pediatric population. So it was difficult to set up a bolus volume for that particular patient. So we had to manually give that. So there was a risk of hypervolemia, giving additional boluses with unknownly, and also a risk of overload. And also the fluid tubing system is sometimes not compatible with lactate containing solutions. So sometimes we had to flush the whole line for a while changing the fluids. So choice of fluid was another challenge we faced. So what fluid to give, whether it is crystalloids, colloids, or blood products. So there were certain concepts and there was certain evidence we had to consider in choosing fluids. So we already knew that according to the existing evidence, the platelets increases the risk of hepatic arterial thrombosis. Now, so giving FFP and packed red cells invariably increases the risk of infections, bloodborne infection transmission, and prolonged ventilation due to transfusion-associated acute lung injury, transfusion-associated circulatory overload, and therefore can lead to prolonged ICU stay. So taking all these things, all these challenges, all these issues into consideration and being aware of them, we change our fluid management in this particular case scenario to more towards the colloids, and among which the 5% albumin took the priority. And to manage the coagulopathy, we use concentrated amounts of pyroprecipitates and FFP. And then the most important challenge we face is the reperfusion injury. So this ischemia reperfusion injury is the tissue injury that occurs when blood supply to organ is interrupted and restored. So that affects both the donor organ as well as the managing recipient. So the donor organ, while during the procurement procedure, it is subjected to cold and warm ischemic reperfusion injury. And at the same time, when operating or anastomosing the new liver to the recipient, we go on IVC and portal vein clamping. That also causes the liver to be ischemic, therefore leading to ischemic reperfusion injury. And then the prothrombotic, not only that, if the patient is having a prothrombotic profile, sometimes the patient might have had portal vein thrombosis to begin with. So that also increases the risk of IRI before and after the liver transplant, because that hinders the blood supply to the new liver. So those were the challenges of ischemia reperfusion injury, and also that causes post-transplant complications as well. And you know already the danger of hyperkalemia, acidosis, and risk of microthrombi being released to the circulation, and the oxygen-free radicals are the main culprits of this ischemia reperfusion injury. Therefore, we had to take proactive strategies to minimize this and improve the graft as well as patient survival. So that is not a single most step that has to be planned from the perioperative period. And this is the most beauty of the case scenario we had. This is the fast track recovery of the patient. In the midst of so many challenges, we were able to sail through all these challenges and fast track the patient at the end of the surgery. So, so that was basically the immediate and early extubation following liver transplant, because that is evidence-based. The early extubation causes better outcome in terms of graft function and shorter length of ICU and hospital stay. And it also has a good association with less pulmonary complication because of the less ventilatory days. And not only that, this fast track recovery reflects the quality of the whole perioperative course. And it's not a single event, but a result of series of planned interventions. So in preoperatively, we have to plan it out, deciding whether the patient needs a postoperative ventilatory requirements, such as hepatopulmonary syndrome that might hinder the immediate extubation. And also we have to optimize the patient's nutritional status and improve the frailty. So those are the pre-op factors we were considered. And then the preconditions during the surgery were far more important, such as achieving normothermia towards the end of the surgery and achieving hemodynamic stability with the minimum use of inotropes and vasopressors. And there should should not be any ongoing evidence of blood loss. And the patient should be having minimum ventilatory requirements like fractional inspired oxygen concentration of less than 0.4 and not requiring higher ventilatory requirements. And also, most importantly, the surgeon should be happy to go ahead with the fast tracking, because there should not be any major early graft dysfunction denoted by persistent lactic acidosis or severe coagulopathy. And also, there should not be any surgical concern about the graft perfusion or raised intra-abdominal pressure. So those were the key concepts of fast tracking and staying ahead of the game to win this game and save the patient and have a good outcome. Thank you. Thank you ever so much.
I just need to butt in here and show you this, the evidence for having dedicated liver transplant anesthetists. We've just started training, at least we started training in 2017. It is crucial that if we are to make maximum use of the commitments or the sacrifices made by the surgeons and the hepatologists in going through specialized training, we have to up our game and have specially trained transplant anesthetists. And this is evidence from the journals, which shows that there's a definite benefit of having dedicated transplant anesthetists. It reduces transfusion requirements, reduces the need for mechanical ventilation, reduces the length of intensive care stay, and obviously makes it easier to work in theater when you have a trained transplant team of transplant anesthetists. And also it considerably increases academic productivity. So it is important to give that serious thought and encourage trainees to take up transplant anesthesia as a subspecialty. As for us at the North Colombo Liver Transplant Service, we started off a long time ago. Way before we started liver transplants, we were doing liver resections, and we used modest evidence-based objectives to guide our management. So low central venous pressure, goal-directed hemodynamic management, low threshold for use of vasopressors, noradrenaline particularly, use of thromboelastometry to guide blood product use, and very conservative use of blood products, aggressive preparation for extubation in operating theater, minimize ICU stay, and always welcoming extended faculty, including trainees. So these are strategies we adopted for our liver resections, which we used and we adopted for liver transplant, and we continue to use them. So stressing the point that we need trainees taking up transplant anesthesia and critical care if we are to move this forward. Okay. I would like to invite Dr. Miranthi Fernando to, before that, sorry, to go through the patient transfer. It was a difficult transfer. It was an unstable patient, but our team pulled it off. Over to you, Roshangani, another transplant anesthesia trainer.
So I'm going to talk about the transfer of liver transplant patient from theater to the ICU. So transporting a patient following liver transplant is a high risk and challenging process. Therefore, all the measures taken to ensure patient safety has to be continued until the patient is handed over to the ICU. So it's a very dynamic scenario where sudden deterioration can occur, risking the patient's life. So our patient on discussion was a high-risk transfer because it's an out-of-house hospital transfer, and it's a pediatric patient, and she was transferred just after extubation. And also she was with a new liver and on vasopressors, and also she was mildly coagulopathic. We had closed loop communication with receiving end prior to the transfer. And also we ensured the patient was resuscitated and stabilized prior to sending. All the monitors, syringe pumps, and ventilator were functioning reliably with adequate battery life. Also, we had enough oxygen reserves for the transfer. And invasive and other monitoring were continued without interruptions, and vigilant monitoring was maintained throughout. If I talk about the transfer team, it was led by our senior registrar in transplant anesthesia, accompanying with another doctor, well-trained nurse, and other healthcare assistants. We had backup personnel and their contact numbers in case of an emergency. So this is a picture which was taken during the transfer of our patient. She had multiple lines which were secured well. She was on noradrenaline infusion, which was appropriately labeled, connected, and functioning well. Also, we had emergency drugs drawn and loaded into the syringes with us. In preparation for worst case scenario, blood and blood products were ready for the transfer in case of worsening coagulopathy. Also, we were prepared for the management of airway in case of pre-intubation. At the receiving end, the consultant pediatric hepatologist, ICU doctor, and nurses were there to take over the patient. There, the patient was handed over with clearly written records. So that is how we managed to transfer this high-risk patient to distant ICU, ensuring the patient safety throughout. Thank you.
Thank you, Roshangani. We move on to the intensive care management. This will be the intensive care management was handled by Dr. Miranthi Fernando, consultant pediatrician. She did an excellent job of managing this patient in ITU. It was a very difficult first 24 hours in ITU, but she pulled it through. Over to you, Miranthi.
So post-op intensive care, yes, as Bhagya mentioned, it was a very big challenge because I'm not a pediatric intensivist. I'm a general pediatrician who got some training with pediatric hepatology. So I had to use all my general pediatric knowledge, intensive care knowledge, and whatever the things which I've learned over the last decade to battle with this patient. So my task was, I received this patient who was quite sick, even soon after the transplant, with all the efforts by our anesthetist. Then I had to take the challenge to make her like this. You can see in this picture. It was a quite big challenge, which was supported by all the team members, and finally we were successful. It was a very big help that anesthetic team had extubated the child on table, and I received the child who was not on ventilator, which was really, really helpful for me to manage within my expertise and capacity. And I think firstly, I should thank two people before I move in with my presentation. Dr. Janaki Disanayaka, the transfusion medicine consultant in Colombo North Teaching Hospital, Ragaman, who provided an excellent timely service to us, and Dr. Pradeep Gamage, pediatric intensivist in Teaching Hospital, Karapitiya, who helped me over the phone, giving his instructions and helping me with managing the hemodynamics. So let's look at the principles in post-op intensive care and management of hemodynamics in a liver transplant recipient. It's very important to monitor the hemodynamic parameters, and it's very important to interpret them correctly, because the child has already gone through a lot of hemodynamic instability despite of the efforts by the surgeons and anesthetists. Certain things are not really preventable. The child goes through a lot of fluid shifts, lot of changes during the surgery as well as during the anesthesia. So it's very important because certain things are manifested soon after the surgery in view of hemodynamic instability. If I tell you our scenario, our child, when the child was taken to the ICU, maybe after half an hour, like we noted that child's blood pressure is dropping. So child required triple inotropes, and we had to give high oxygenation to maintain the oxygen saturation. More than that, child was hypothermic. We were not sure what was the exact reason, maybe a septic trigger which had occurred intraoperatively or maybe prior to that. Due to some reason, it was very challenging to maintain her hemodynamics. Apart from that, she had a high drain output since beginning, which contained a lot of proteins, which not everybody is aware of. So we had to think about that aspect, and that protein loss related coagulopathy was looked into. And timely detection of bleeding. I would like to really highlight the fact about bleeding, because if you have a discussion about post-transplant care, I'm very sure everybody will talk about thrombosis, and everybody is scared of thrombosis. But very limited people talk about bleeding. Actually, I'm more scared of bleeding than thrombosis. Maybe I'm not the surgeon, I'm not going to operate. That may be the reason. However, bleeding does result in death. So it's very important to detect bleeding and address bleeding. And I'm equally scared of bleeding as well as thrombosis. So that's very important to detect. And timely detection of sepsis and acute kidney injury. Even our patients sustain an acute kidney injury, possibly multifactorial. The hemodynamic changes and maybe the drug-induced kidney injury, because we maintain a high level of immunosuppression immediately after the transplant. So all these factors would come into play. And in principle, we have to think about immunosuppression, antimicrobials, antithrombotic medications. Importantly, continuity of care. We have a team, and every team member is crucial for the successful management. But when it comes to decision making, the continuity of care is very important. I think that is which made our child to survive after all this battle, because one person should be monitoring the child throughout, understanding the trends and interpreting the trends correctly while you're getting the opinion from the rest of the team members. And I should be thankful to my team. They really did provide me the freedom to manage this child with my expertise and with their opinion. So that was very helpful. I was able to manage this child freely while monitoring the patient throughout in the initial few days. To manage the post-operative period intensely, because it affects the graft survival. We are talking about a 9-year-old child who's going to live with this graft maybe next 60, 70, 80, 90 years. So it's very important. Each and every insult would result in adverse outcome. And this graft should last long. This is a 9-year-old child, and this is where we start the journey. So in this child, what we did was we monitored the hemodynamics very carefully, all the vital parameters we do normally. And I had the luxury of having all the central venous line and venous access, which was done by a nice anesthetist. And I had all the monitoring devices and their help in interpretation. And of course, the extubation was done prior to the intensive care arrival, so that was helpful as well. So immediate post-op, what did I do? So we started monitoring the vital parameters, and The child was hypotensive initially due to some reason. So I had to start on inotropes. Actually, the child was on inotropes as well as vasopressors. So we had to pick the blood pressure up with the volume as well as with the help of the inotropes and vasopressors. To avoid hypothermia, actually to treat hypothermia at that point, we had to rewarm the child and to maintain the temperature. Input-output wise, we normally restrict them to 80 to 90% post-op. However, as this child was hypotensive, I was unable to do that. So I gave the full maintenance, and apart from that, I had to give colloids, which I used initially 5% albumin, as well as in certain occasions, depending on the volume stability, I had to use 20% albumin as well. And subsequently on day 1, I had to use a blood transfusion because of the bleeding through drains. That was guided by Rotem with the help of our transfusion medicine consultant. And then we did not give heparin, though we normally give heparin in the initial period, though as our patient had bleeding, we did not give heparin. The risk of bleeding depends on several factors. Our patient had persistent fibrinogen deficiency, which is actually expected and well documented in certain cirrhotic patients. So that contributed to bleeding in our patient mainly, as well as the high drain output, which was there since beginning. So we did not start heparin since beginning, though that is the standard protocol because our patient had bleeding. Immunosuppression, we started with basiliximab in the theatre, and then subsequently we started with tacrolimus as well as azathioprine once the patient was able to take orally. Nutrition, we started as early as possible when the child started bowel opening, and after discussing with the surgical team, when they are happy for us to start oral feeds, and mobilization was done early, and chest and lymph physiotherapy were started. Antibiotics, we started with broad spectrum antibiotics because child had a septic trigger possibly to result in hypotension and initial hemodynamic instability. So we gave antibiotics as well as antifungals, and she was anyway on antiviral prophylaxis as per the standard protocol. So a little bit about transplant immunology. The liver graft requires lifelong immunosuppression to prevent rejection, unless it is an auxiliary transplant or hepatocyte transplantation, which is beyond the scope of this talk today. And normally the grafts are ABO matched, and special consideration should be taken when you decide on immunosuppression protocol in autoimmune liver disease or PFIC type 2. So in our child, we started with basiliximab, and we started tacrolimus on day 1. Then we added azathioprine once the child was on oral feeds by day 2+. That was the protocol for our child. And initially, I maintain a high level of tacrolimus as the risk of rejection is quite higher in the initial period. However, we have to keep this in mind because the children are going to last long with this graft, maybe 80, 90 years. So we have to balance the risk of cancer and PTLD while we are avoiding rejection as well. Just a little word about rejection. As I said earlier, the highest risk of rejection is soon after the transplant, and risk will remain. But the level of TAC we normally maintain with time becomes low. Initially, we try to maintain a high level of TAC. That would have some implications on renal functions, because if you have a child who had hypotension, if you have a child who had hypoxia, hypothermia, there were multiple hits to the kidneys, and we use several antimicrobials, which again has got drug-induced effects on the kidneys. And on top of that, if you are trying to maintain a high tacrolimus level, again that would impair the renal functions further. So we had that challenge. So I had to balance the pre-renal, renal, post-renal components of acute kidney injury. However, with volume replacement as well as modification of our drugs, we were able to get top of that. And in view of rejection, we know that it could be cell-mediated rejection or antibody-mediated rejection, or it could be acute rejection or chronic rejection. We keep all these things in mind when we plan the immunosuppression. Post-op complications, I'll briefly touch on this. I think Dr. Sushinta will talk about this in detail. The immediate complications like vascular complications, hepatic artery thrombosis, portal vein thrombosis, or outflow obstruction. In fact, our child did sustain outflow obstruction. Bleeding again often overlooked, but that does occur. And biliary complications, biliary leaks, and biliary strictures. Primary graft non-function. It's kind of a famous term. When the children die soon after transplant, we normally call it primary non-function, and that's kind of a term where we really can't find the etiology. People have postulated several theories for this. It could be an early rejection, it could be a vascular complication like at microvasculature level due to some reason where you can't really identify the reason, however the graft fails. Infections, again, a great risk to the graft, and you can find out about infection if your lactate goes up. Sometimes child might not develop the temperature because child is on immunosuppression. So the standard signs of infection will not be there. You have to simply look for the tachycardia, raised lactate and other parameters to diagnose the infection and escalate your antimicrobials. Rejection can occur even first week of post-transplant period. And as I mentioned, acute kidney injury should be taught when you manage your drugs as well as your fluids. I think this would be a good point where Dr. Sushita can come in and tell about the complications, post-operative complications, the surgical team.
Meranti, no, slight change in plans.
Okay, sure.
Rushing to theaters. I would like to ask Udya, the consultant intensivist at North Colombo Teaching Hospital. Udya, how would you, what would you see as the salient differences between an adult post-liver transplant patient, managing a post-liver transplant adult patient versus managing a child post-liver transplant?
Yes, compared to the pediatric population, the adult population that we see is coming with a lot of comorbidities. And because of the ongoing organ failure going on for a longer duration, there is an invariably other organ systems are affected to a greater extent. And they are coming with advanced multi-organ dysfunction state. So it's becoming quite challenging for us to manage that kind of patients. And also with advancement of the surgical skill and also the expertise available, we see more sicker patients are listed on the transplant list. So again, it add challenging situation to the critical care settings. So however, we have developed our critical care settings with all these advanced equipments and the expertise managing these patients. Providing 24-hour on-call support. Along with the other multidisciplines, we make collaborative decisions. So that has shown very impressive outcome over the preceding years, giving very good outcome in liver transplant patients. That is very reassuring.
Yeah, one of the reasons that we are getting bolder in listing more sicker patients is because we have better intensivists in ICU who are very clever at managing these very sick patients and giving us good outcomes.
It's not only the it's a teamwork, sir. So anesthetist, and they have nicely done the surgical procedure and everything done, and also expertise available at any time to make right decision at the right time, and proper intervention makes the better outcome in all these patients.
Thank you, Udya. Well, the future of liver transplant at the North Colombo Liver Transplant Service. We are looking at focusing more on pediatric liver transplants because there is a huge need for pediatric liver transplants. There are a lot of sick children with end-stage liver disease who are seeking our help through the transplant clinic. We are also finding it difficult to get cadaveric donor organs because not enough brainstem testing is being done, and we are yet to have a equitable organ allocation system. I'm sure that will be rectified in the near future. So we are looking more and more at doing live donor transplants and improving our services and to provide better services to the general public. We will also do our best to develop training facilities for surgical trainees, the medical trainees, and the anesthesia critical care trainees, because they are the future. and they are the ones who will carry this forward. And I'm sure they'll have a very challenging job to do in the future, because all these patients who have been transplanted, or at least some of them, will need retransplants and will come in with long-term complications of transplant and immunosuppression. So they will have to handle these in the future. So hopefully they'll be up to the task. Thank you very much, all the panelists who worked very hard to bring this, make this a success. And a huge thank you to the audiovisual team, Vinol, Malan, and the team for being very patient with us and making this happen. Thank you very much.